Good evening, dear students and dear colleagues. And today I want to concentrate on an important topic, which is including the potassium management in hemodialysis. It's fundamentally a rhythm safety strategy. And throughout this lecture, I will focus on the timing, dialysis, gradient, rebound physiology, and system reliability. The risk equation that is built is put here under the abbreviation of the TIGRIS, and it is include the T, which is the timing, that the potassium risk in hemodialysis should be interpreted through four integrated domains. And the first one domain is the timing of the exposure to dialysis. The second thing is the serum to dialysate gradient, and the third one is the post-dialysis rebound physiology, and the last but not the least is the chronicity and the system follow-up. The dynamic effect of potassium during and after hemodialysis is shown in this figure, and it's including in the to start with, before dialysis, the potassium is going to get up. Once dialysis is started, the extracellular potassium is only a small compartment, and there will be rapid removal of this extracellular potassium from the vascular pool by the dialysis. Post dialysis, so the curve second line, it get dropped down, and then after post dialysis there will be a rebound, but this rebound which got upward, the longer the interdialytic interval between the sessions, especially in the midweek, if it is longer, so there will be more rebound and there will be more elevation. So the interdialytic interval will changes the risk context in this issue. The urea dose does not fully predict the potassium safety. The important thing in the management of the hyperkalemia is to stabilize the membrane. And this is especially when there is an ECG changes are present. But the giving of the calcium gluconate, although it stabilizes the myocardial membrane, but it will not remove the potassium and lower it. The second important thing is to buy the time by shifting the potassium from the extracellular to the intracellular compartment using insulin, hypertonic dextrose, beta agonists, bicarbonate. But we have to keep an idea that when we shift these using insulin, glucose, and the patient in end stage kidney disease, so there is a high risk of development of hypoglycemia. So glucose monitoring is important for any possible delayed hypoglycemia that can be developed. Then the most important step, which is the removal of the potassium by the dialysis. So the active or the actual removal is by dialysis. And the third is to look after removal and to prevent the rebound, as I explained in the previous slide. The emergency prescription is effective. It's not reckless, and we have to ensure the adequate treatment time of the dialysis, the ratio of between the velocity of blood QB to the QD, and also QA to QB at the same time, the dialyzer size and type, and the vascular access performance. Then what is the potassium bath that to be used? And although that K1 bath of the potassium, which means that a concentration of a potassium in the concentrate, dialysate concentrate, is 1 millimole, it's not a routine setting, and if it is used, it carry a high risk in this intervention. We have to document the monitoring and the exit criteria for not only K1 bath, for all K3 and K2 bath, and we have to check the potassium, glucose, and we have to check the rhythm of the patient, and this is an important issue, especially in patients with arrhythmia or with intradiabetic hypotension. The final step is the critical, because chronic hyperkalemia management is incomplete without reassessment of the intervention. So we have to verify the pattern and long interval versus all sessions versus post hemodialysis low potassium, and we have to check delivery of dialysis, as I mentioned in the previous slide, including the single pole KT over V trend and the any alarm, any missed dialysis session. Again, we have to check the audit drivers like the constipation if present in the patient, when the patient is used certain additives in his nutrition, and the binders of the potassium, and if there is any acidosis or alkalosis, and at the same time in those patients with certain dietary habits, especially the weekend habit when they have a liberal intake of the food, and the catabolic state. And again, we have to review the drug that is taken by the patient, which include the drug that affect the potassium and increase it, and that involve the non-steroidal, the mineralocorticoid receptor antagonist, and RAS blocker, and if there is any supplement. And then we have to intervene regarding the time, the frequency of the dialysis, which K-path is used, the binders of potassium, medicine, whether additives or whether a drug that, as I mentioned, increase the potassium. And we have to make a remeasurement trend because a long interval potassium, we have to de-escalate low bath risk at the same time. This is very important, which is usually not taken in consideration. That is the serum to the dialysate or to potassium bath gradient. So if, for example, in the first line, which is the potassium in pre-dialysis is 4.5 millimole per deciliter, then the safety when the gradient between serum potassium and between the K-bath is not more than 2.5 and not less than 1.5. But if we use a bath of 1 potassium millimole in a patient with a pre-dialysis 4.5, then the gradient is in the orange, which is the modest, that is to say there is a risk, or because the gradient is 3.5. Again, if the patient presented in the second row with a serum potassium of 5.5 in the same pattern, that is the bath K3, is the safer for him, and making the difference between serum to bath is 2.5. But if the level of the gradient is more or equal to 3.5 and 4.5, then there should be a caution in such a situation. And so we have here what is the drivers is the pre-potassium and at the same time the dialysate potassium. So if a 6.5, even when I use this of 6.5, when I use a potassium bath of 3, the gradient will be 3.5. So in this condition, I have to be in a caution. I never use K1 potassium, just thinking of lipid lowering, because the higher the gradient between the pre-dialysis potassium and between the the dialysate bath potassium, the higher risk of the development of the intradialytic hypokalemia and rebound hyperkalemia, and both of them can result in the development of the arrhythmia and other complication. So here, how does this intervention change the burden, gradient, rebound, or reliability? I have to think of the binders or a burden reducer. That is when the serum potassium is, especially in chronic hyperkalemia. And in general, when the serum potassium is more than 6, the safer bath is important. We have to also take in consideration drugs which is given, or the interval between dialysate, and what are the comorbidity, and which are the binder that is used, and its complication, that is, for example, the sodium zirconium trisilicate, which cause an edema on sodium concern, on the patyromere, which cause hypomagnesemia and can also produce GIT upset. So here important is to consider the drug. The other thing is to consider a limitation of the diet without causing malnutrition to the patient, and that to determine what is the target potassium are required in that patient and what are the salt substitutes or supplements. And at the same time, we have to think of the processed food which use most of the often containing high potassium, and what is the weekend pattern that most of those patients among their families, they may have a certain food uncontrolled food habits, and this can also cause a problem. And the other are the group of the patient who cause constipation, and this is not a blanket prohibition of diet quality. The drugs, as I just proceed now, that is important, and to have to balance between the need for control of hypertension or heart failure and the use of mineralocorticoid and renin-angiotensin. So if by dietary control, by dialysis, and by the binders of the potassium, I can control the serum potassium in even up to 5.5, up to 5.5, sorry. So in this case, it's okay. But if the potassium is continue too high, and then there will be a dangerous risk of hyperkalemia. In that condition, we have to even given a sick day leave, at least stop it and correct, and then we can reuse it again because of its indication. As the hyperkalemia is risky, hypokalemia is risky, and I mentioned that the higher the serum potassium, the lower the K-bath use, the higher the incidence of the because of the high gradient of intradialytic hypokalemia and postdialytic even at the last hour or even postdialytic hypokalemia. This is a quality of a prescription signal. It reviews everything, not only the dialysis adequacy. It includes the nutrition, the drugs, the binders, the constipation, and the type of the bath which is used and the duration. And the most important thing is how long is the interdialytic interval. Sorry. This is just to speak about the a certain case presentation that is a complete emergency hyperkalemia sequence in dialysis patient. This is a case when the potassium is high, and in this patient we have to presented with a serum potassium of 6.5 in the previous slide. I cannot go back, and because of that the treatment, it should be started and not wait the dialysis, because dialysis may need 45 minutes to be prepared for machine preparation, for rinsing, and so this patient should not be shifted immediately to the dialysis unless we have given a certain control. That is to say, membrane stabilizer should be give a calcium chloride or calcium gluconate, and this, as I mentioned, will not decrease potassium but will protect the heart and stabilize the membrane of the cardiomyocytes. The second action that I have to buy the time with it is to use shifters that are the we have to change the acidosis into alkalosis by bicar, use of sodium and insulin and the glucose, and at the same time the use of beta-2 agonist. Then after we have this enough time to stabilize and to protect the patient from risk of arrhythmia of hyperkalemia, then we have to shift the patient into dialysis, which is the actual removal. And after that, we take in consideration that we are not in a hurry and we don't need to make a high gradient, and then the risk of post-dialytic hypokalemia subsequently there will be because of very high level of potassium is expected to get a rebound hyperkalemia, and we have to put an eye after finishing the session of dialysis. There is a risk of rebound in several hours, and we have to check the potassium after the dialysis. So this case, which is the second one, is to highlight the importance of recognizing long interdialytic interval hyperkalemia as a distinct physiological and behavioral pattern rather than a dialysis delivery failure. This patient is presented because of the repeated Monday serum potassium is 6, which is to some extent accepted. But what happened, because in pre-dialytic there is a hyperkalemia, and we defined hyperkalemia as more than 5.5 millimole per liter, and serum potassium less than 3.5 millimole per liter is defined as hypokalemia. So in this case, we have a patient with a Monday, that is to say, a pre-dialysis hyperkalemia. But in the midweek, that is to say in the Wednesday or Tuesday, the patient's serum potassium is good, 5.1. But the patient is on a 2 dialysis sessions per week, and this is causing an incomplete session, and probably not only because of the interval between the two dialysis sessions is long, probably other factors may also act, like the excess failure or vascular problem or a lot of alarm of the machine. And on the other hand, maybe the compliance of the patient, that to say the patient, he is not regularly attending the dialysis, and this is quite often happen in certain non-compliant patients. So the longer the interval, the higher is the hyperkalemia. And here in this patient, we have not to just concentrate on on the mid-week potassium, which is good. We have to concentrate on the pre-dialysis potassium. That's to say, we have to increase the frequency if other factors are all working and there is no problem with it. So we have a recurrent long interval hyperkalemia should be managed with a targeted physiological and behavioral intervention rather than reflexive of chronic reduction of dialysate potassium excretion. So the answer for this patient, we have to verify the pattern. Is it a long interval, or is all sessions maybe the patient non-compliant? On the other hand, of the risk of post-hemodialysis hypokalemia, because the rebound is expected again here. We have to check the delivery time of the dialysis, the vascular excess, what is the adequacy measured by the single ball KT over V trend. If it is 3 times per week, we can take it per one session, and we can take it if it is less by a week. Any alarms from machine because of the complication, whether in the vascular excess or whether in for example, blood pressure, and if there is any missing of a sessions, whether intentionally or not, from the patient. And we have to check the other drivers, which include the constipation, additives, acidosis, diabetes, and catabolism. So in this patient who is with pre-dialysis, early week potassium 6 and mid-week dialysis potassium and serum potassium is 5.5. This is a weekend diet, additives, constipation, binders, timing, adherence to dialysis, other comorbidities, acidosis. We have to consider a longer Friday session or binder before chronic low bath reflex. And what we can take home message, and when we can conclude, we have 4 important principles in the potassium management. That is fundamentally, from the beginning of the lecture, I say it's a rhythm safety strategy. The hyperkalemia required stabilization, intracellular shift before we are thinking of definitive removal, and we have to think of the rebound prevention, and we have to think of chronic dyskinesia and kalemia that require system-based correction before escalation to a chronic potassium dialysate exposure. So these are the most important 4 points that I mentioned here. I have to consider the rhythm, not just the chemistry. In acute, I have to stabilize and shift before think of removal, and I have to think of rebound. In chronic, recurrence is important. It is not just a reading of potassium. It should, in the chronic cases of, we have to think of the chronic correction of the potassium before a chronic low bath exposure. And one important thing that the potassium, we have to follow the unit control of the potassium. We have, I think, on the slide which is missed, it was showing the two group of the patients who started with a percent of 18% in our unit of patients at the beginning of this year having the hyperkalemia and above 6.5, and we have around 8% of them having their hypokalemia less than 3.5. And after the management till now of the 6 months, we have the percent of the patient who sustain hyperkalemia among the first group is 8%. So 10% get improvement within 6 months and 8% sustainably having hyperkalemia. And this group, we have to check the patient, the treatment and the unit all together to identify what are the reason behind the persistence of hyperkalemia in this 8%. Is it because of the patient compliance, his management, his diet, or it's because of the dialysis adequacy that include the vascular access and include the duration on dialysis, the interval of dialysis, and which bath is used, all these and others to be taken. And at the same time, we have to concentrate on accuracy of the lab results. And again, in our unit, we have a percent of patients who got from the beginning of the year hypokalemia, it was in 8%. Till now, after 6 months, they decreased it to 3%. So again, we have a persistently having hypokalemia. So those group with sustainable hypokalemia less than 3.5 over the last 6 months, again, this group should be taken consideration. They are over limited in their dietary intake or in the additive intake? They are taking potassium binder more than accepted doses and frequency? They are treated more frequently? They are using a low K bath like potassium 1 or 2, and in that case we want to shift them into K3, which is the safer in most of the patient. So after all, we have to consider that the potassium control, if it is a chronic, it requires system-based correction before escalation to a chronic low potassium dialysate bath and exposure. And I have to, at the end, to thank you for this listening. And please, if you are interested in a full lecture, PDF lecture, just scan this QR code. Thank you very much.